Hello, my name is Dr. Sandra Jan. I'm an adjunct clinical affiliate at the University of Texas at Austin School of Nursing, and I'm also a psychotherapist in private practice in Austin, Texas. I am a proud member of the Psych Congress Steering Committee and our Psych Congress family. During these rough times, we're hoping that everyone is well. I'm so happy that you've joined us today as we continue this educational video series addressing tardive dyskinesia and coping during the COVID-19 pandemic. This program is approved for 0.25 continuing education credit, and the series is supported by educational grants from Teva Pharmaceuticals and Neurocrine Biosciences. I'm so excited about today's topic, establishing optimal TD treatment strategies and patient access plans. And today's guest expert, Dr. Sanjay Gupta, is a leading expert in this area of practice, and we're very lucky that he's joined us for this important conversation. Dr. Gupta is Medical Director, Geriatric and Adult Psychiatry, Mid-Erie Clinic, and Clinical Professor, SUNY Upstate Medical University at Syracuse, New York. It's great to have you with us, Sanjay.
Thank you. Pleasure to be here.
Taking care of patients with TD, as we all know, it can be a challenge, but it's also an excellent opportunity to take great care of our patients. Sanjay, considering pharmacological treatments, what FDA-approved options do we as clinicians have available to us for the care of our patients?
Sandra, this is a very exciting time. I am way past my residency, and I was at that time very interested in tardive dyskinesia because there were all these patients and we couldn't do much about them. And this condition was described in 1957 by Schoenecker. So it's really nice. In the last few years, we've had 2 FDA-approved treatments. We've got valbenazine and deutetrabenazine. Valbenazine was approved, if my memory is right, April 2017, and deutetrabenazine, August 2017. So it's really very fortunate, and I think it's an exciting time, and I feel very excited about it as a practicing clinician, that I can do something positively and change the life, socially also of these patients.
It's great to know that both of these agents are available, but I'm wondering, can you also talk to us about how to best navigate the patient access plans to these 2 VMAT2 inhibitors?
I think I have now in the last many years learned many things about access. And I think the most important thing, in my opinion, is to do an AIMS exam and have the AIMS score. And then you put the diagnostic code for TD, which is G24. So when you have this documentation, that is highly unlikely for one plan to refuse versus another plan. I think the point being, some plans may preferentially have one drug, another may have preferentially another drug. But to have access to at least one agent is not an issue that I have seen in my practice. I've been using these agents now for the last few years, and it just doesn't seem like a lot of work to get access, unlike getting some new antipsychotic drug accessed or a new antidepressant access.
Regarding VMAT2 inhibitors, are there any specific adverse events that clinicians should be aware of? And if so, would you be so kind as to walk us through how to mitigate these adverse events?
Thanks. I think that's an extremely important question because in prescribing medications, we need to monitor for adverse events. But before I get to adverse events, I just want to share there are 2 VMAT2 inhibitors, valbenazine and deutetrabenazine. The most important point first is to diagnose tardive dyskinesia. And here I would say, what the mind does not know, the eyes will not see. So you got to be thinking about TD, and then you will catch it. And in our clinic, we have trained multiple people to look for TD. For example, the therapist is also trained because the patient spends a lot of time in front of the therapist. The front office staff, they're just trained to watch the mouth, okay? Because the face and mouth are where most of the movements are. Now, let's get to adverse events. So if we look at valbenazine, well, the commonest adverse events is sedation. So, and it's usually not that common, okay? I think if you give it to 14 patients, one may have sedation. So that's fairly low frequency. And I think what we do is, I would inform the patient about sedation, akathisia, some worsening of Parkinson's, that's a warning, and hypersensitivity. And they can watch out. You have the titration also, 40 milligrams going to 80. It can be given any time of the day. But if the patient is sedated, you give it preferentially at night. And if they're on some other medicine to help them sleep, maybe you can back that off. So there are many tricks that we as psychiatric clinicians have that we can put into practice instantly. If we look at sometimes there's lack of tolerance, like GI distress. Different things happen to different patients. I've told them to, put it in peanut butter and take it, So you try different things. If you look at the other drug, deutetrabenazine, maybe they have GI distress. Again, same thing. We split the doses. You got to make sure that the medicine is given with food. It's given twice a day. If people have adverse events, you back off. So deutetrabenazine has titration. You start at 12 milligrams a day, broken into 2 doses, 6 twice a day with food. And then you escalate the dose by 6 mgs every week. And you may need to get to 48 milligrams total dose. What if some adverse events occur? I just back off the titration and do it slower, or hold the dose, because every patient doesn't have to go to 48 milligrams. The average dose was, I think, 38.3 or something. So I think people may get better on lower doses also. So I think there's a lot of tinkering that can be done. And I think in the mental health world, we as mental health clinicians are very well familiar with tinkering that goes on. So I think one has to mix and match and try different strategies for different patients. But in general, I would say both agents are fairly well tolerated. Also, if I've started one on valbenazine and they had some adverse events that I can't manage, after trying, lowering the dose, trying a slow titration, trying many things, I might switch to deutetrabenazine. Similarly, if I've had somebody on deutetrabenazine and I can't manage those adverse events after a reasonable trial, switch to valbenazine. You can make these switches. And I think the important point here to make is we have 2 agents. So if you have trouble with one, you can switch to the other. That's also another strategy.
So Sanjay, as we broaden our knowledge and skills in taking care of our patients with TD, would you talk to us about your best practices when it comes to 2 things: symptom monitoring and dosage adjustment of VMAT2 inhibitors?
Great question, because this is something that comes in practice, and we got to utilize this, and patients need to be monitored. So firstly, I explain to patients when we start a VMAT2 inhibitor that this medicine is working for you, and if it works for you, you're going to take it for a long time. I tell them this is just like if you were on high blood pressure medicine, because that's how it's indicated, even though the data for different drugs is 2 years out, 1 year out, and so forth. But ultimately, this is a lifetime drug. And so I basically tell them it's for a long time. We try to simplify their regimen. And periodically, we monitor using AIMS scales, okay? The idea being, if a patient, so let's say if a patient doesn't have Tardive, if they're on a 2nd generation antipsychotic, I tend to do AIMS at least once a year. That's a New York State guideline, at least once a year. if they're on a first generation drug, I double it, so every 6 months. If they're a high risk group, I might do it every quarter. It's kind of like that. And of course, at every visit, you're vigilant too, but these formal exams is what I'm talking about. Because I think there are certain high risk patients like those with mood disorders, those who are, older agents, postmenopausal females, drug abuse, and those having extrapyramidal symptoms and diabetes. By the way, diabetes is very common in our population, and also diabetes increases the risk of TD. So monitoring done by AIMS for symptoms, okay? The other thing I'll tell you what I've done is it's a little out of the box, that I have now a bunch of patients that I get their permission and I make a video of the AIMS being done on them pre-drug, whether I'm starting valbenazine or deutetrabenazine. And then I might make a video 6 weeks later, okay? And then another one, and I show them the video to see that they've improved. And this goes back to old times when people used to make videos of patients who have severe psychosis and then show to them when they had healed, and this enhanced compliance. So I find that this to be quite effective in enhancing compliance using videos.
We appreciate you taking the time to be with us today, Sanjay. Would you share with us your top 3 takeaways from our conversation today?
Thank you, Sandra. This has been great fun doing this. My top 3 takeaways would be, number 1, I think we need to screen patients. So you really need to be thinking about TD. Again, like I said, what the mind does not know, the eyes will not be seeing that. 2, collaborative approach, very important. And 3, don't hesitate to treat TD. Changing the dose of antipsychotic medications could result in a relapse, rehospitalization, return of mood disorder, bipolar disorder, whatever basic illness the patient has. So I think it's really important to treat as is. And the last point I'm going to add now that we didn't touch upon is to avoid anticholinergic medications if possible. Cut the dose down or take them off altogether if you can. Why? Because anticholinergics can bring out subtle TD and make TD worse because they upset the dopamine cholinergic balance in the brain. So I think those are my 3-4 takeaways. Thank you.
Absolutely. And I know that our Psych Congress viewers, they're going to put all this information to really good use in their clinical practices. So in parting, we hope that everyone stays healthy and well. Goodbye.